Welcome back to my channel. So I'm just going to give y'all a quick update what's been going on with me. So recently I went to the eye doctor and I didn't have the 20/20 vision in my left eye, so now I'm wearing glasses. So I pretty much use them for reading or when I'm watching TV. So I just want to give you guys a quick update. Also, uh, while I was in the process of getting that done, I have been diagnosed with hyperthyroidism, and I have been having the symptoms for a little while. I just really honestly didn't recognize them. It was barely detectable in my blood. So my doctor did run the labs, and I was just kind of shocked because I don't have a diet high with iodine. I do eat fairly healthy. So this is a new adjustment for me and just working as well. And recently I have went on a couple of interviews, and as you know, you guys, I started off in the med-surg unit a little over a month ago. And the environment just was not it for me. I love doing the skills, I love the patients, but I just did not care for the environment. So I decided I was going to either leave or go PRN. So in the process, I have went on probably 7 interviews in the past 2 weeks, and a lot of the options were pretty good. I had a offer to a peds clinic, offer at a cardiology clinic, offer at urgent care, offer at a family clinic, a skills unit, and pretty much a few other things as well. So today I finally made my decision that I was going to go with the urgent care and just get a PRN job or do PRN at the med-surg unit to have those skills going. Because at the urgent care, where I will be working at, I'm honestly um, really excited because we still get to do IVs, blood draws. Sometimes we may have to hang fluids. Of course, giving injections and assessing the patient based on the symptoms they're there for. So I'm pretty, really excited, and I am in the process of preparing for my TEAS exam, which is next Tuesday, because I'm applying for the LPN to RN Bridge program at my school, and I'm just testing it out just to see. It's not gonna make or break me if I get in the first go around, but I just wanted to, you know, try my chances, especially since I just graduated nursing school, and I would kind of like to just go straight through and finish rather than, take a break. But it's really whatever is in plans for me. I'm just going to pray about it and make the best decision. Before I get started today, I would like to ask you guys a few questions. If you're currently a nurse, which department are you working in and do you like it? What are your expectations of the job? Are there any room for growth there? And if you're a new graduate or currently in nursing school, what specialty are you interested in? And what expectations do you have for the job? Financially, the working environment, the type of people you're working around, the type of skills that you may use or lose depending on which specialty area you decide to go into. So I just really want to get to know my subscribers. So every video, I want to probably ask a few questions. And if you would like, as much as I do, I would like you guys to comment and answer the questions that I do go along asking you in the beginning of my video. All right, guys. So this is going to be part 2 of Study With Me NCLEX Prep 2020. So I'm going to go ahead and get started for you guys. I'm going to start off talking about maintaining fluid and electrolyte balance. And guys, I will be looking down sometimes to look at my notes. So your body always wants to achieve homeostasis, which indicates the relative stability of the internal environment. But you guys, sometimes that does not happen. Your body can go into fluid volume excess or fluid volume deficit. So, and that is due to electrolytes in your body. Your kidneys also play a major part in that as well. And your adrenal glands, because they regulate the amount of sodium being retained or absorbed by the kidneys. So first I'm going to start off with fluid volume access. So we want to definitely know the symptoms of that. And these symptoms could be distended neck veins because your vessels are full. Also peripheral edema because your vessels can't hold anymore. So they start to leak. The fluid starts to leak out of the vessels. And then your lungs may have wet crackle sounds. Patient could be short of breath. The patient will also have polyuria, which is excessive urination, and increased pulse because your heart is trying to work so hard to get the fluid going forward. So your arteries will be full and bounding. Your blood pressure is high because for blood pressure, more volume equals more pressure. And of course, a patient that has fluid volume excess is going to have an increase in weight. So you will see a lot of your heart patients. Okay? Fluid volume excess is caused by overhydration of fluids, kidney damage, heart failure, long-term use of corticosteroids, excessive sodium intake, syndrome of inappropriate antidiuretic hormone, and so on. So you're definitely going to be looking for a patient if they have a cough and dyspnea, lung crackles, increased respiration and heart rate, increased blood pressure, edema, of course, weight gain, like I told you guys, neck and hand vein distension, increased urine output, confusion, and they also could have a decreased hematocrit level. You want to have that patient on a low sodium diet. You want to restrict fluids. You want to check into INOs and daily weights. You want to monitor that very closely. You want to have that patient positioned in semi-Fowlers. You want to continue to check that patient for edema. You also may be administering diuretics to that patient, and a few of them are furosemide, thiazide, and spironolactone. So it just depends on what that patient particularly has going on first. So with furosemide, we know that the patient loses potassium as well as the thiazide. So sometimes patients are prescribed the spironolactone because they may need to keep potassium because they're losing it. But when you do that, you do have to look for hyperkalemia, signs and symptoms of hyperkalemia. All right, and that's pretty much it for that. But when you think of fluid retention, you always want to think that there's some ongoing issue with the heart. Switch gears and talk about fluid volume deficit. So for that, that's when dehydration occurs in the body, when fluid intake is not enough to meet the body needs. So shock is a very big thing that can occur. It's very important to know. So causes of fluid volume deficit can be vomiting and diarrhea, GI suctioning, ileostomy or colostomy drainage, wounds that are draining, burns, fistulas, and also an increased output from the continued use of diuretics. So because of that, we do want to look at what are the symptoms that may occur. So that patient may have a decreased weight, decreased skin turgor, dry mucous membranes. They might be very thirsty. Their heart rate is going to be increased. They're going to have a thready pulse. They also may have dyspnea and postural hypertension. So that's when you move the patient and based on their position changing, their blood pressure drops. They also might be confused and have an increased level of hematocrit. So, interventions is based on what caused the fluid volume deficit. So, if they're having diarrhea or they're continuing to vomit, of course, you're going to give them an anti-diarrhea or antiemetic, antipyretic, and an antimicrobial might be necessary. You're going to continue to monitor vital signs, respiratory, and also the neurological status. and you may have to administer oxygen if it's prescribed. You're going to, of course, check the mucous membranes and the skin turgor. With skin turgor, we know that what you want is the skin to go back into place in less than 3 seconds. And then you're going to check the daily weights, intake and output, and you're going to test the urine for specific gravity. And of course, you're going to monitor your electrolyte levels. So that's what's important when going over a patient that might have fluid volume deficit, because you want to prevent further losses. And treatments, you might also give that patient PO fluids if it's mild, but if it's severe fluid volume deficit, you're going to give them IV fluids. And you're going to put in safety precautions, of course, because they're higher fall risk due to their mental status change. All right, so now we're going to talk about potassium. So your normal potassium level is from 3.5 to 5. And so you can have hypokalemia, which is low potassium, or hyperkalemia, which is high potassium. First, we're going to discuss hypokalemia. So, that's a level of potassium is lower than 3.5. So first, we're going to discuss the causes. And the causes of hypokalemia is vomiting, NG suction, diuretics, not eating because you're not obtaining the potassium you actually need to gain. You're not eating anything with potassium. Of course, you're not getting any potassium in your system. If you're taking diuretics and it's not a potassium sparing diuretic, you're going to lose it. Vomiting, you lose potassium, and the NG suction, because we have a lot of potassium in our stomach. So, common foods that you would want to eat for potassium are avocados, bananas, cantaloupe, oranges, strawberries, tomatoes, carrots, mushrooms, and so on. So, other causes of hypokalemia would be the inadequate intake of potassium, of course, excessive fistula drainage, Cushing's syndrome, chronic use of corticosteroids or laxatives, kidney disease, TPN, uncontrolled diabetes, and alkalosis. So signs and symptoms. The major signs and symptoms for hypokalemia would be muscle cramps and muscle weakness. And you would also want to be on the lookout for life-threatening arrhythmias. The patient can also have leg and abdominal cramps. They may be lethargic and weak. They may have shallow respirations and a thready pulse. They can be confused, hypoactive bowel sounds and the ileus, as well as postural hypertension. So in order to treat hypokalemia, of course, you want to give potassium. So you're going to give potassium. If the patient needs a diuretic, you can also give them spirulactone because it's potassium sparing. If the doctor has prescribed it and you want to push the patient to eat more potassium, and like I said, you would get them to eat like avocados, bananas, strawberries, oranges, that sort of thing. For giving the patient oral potassium, you need to be aware that they will have GI upset, so that's something that you may want to educate your patient on. You also want to always assess the patient's urinary output before even giving potassium, because the kidneys excrete potassium and it allows you to know if the kidneys aren't working well or if they're working well enough, as well as when you give the patient potassium through an IV, you need to let them know that it will burn, because potassium is a very potent medication. Because you're giving potassium through the IV, you need to take a close look at their peripheral veins, because it can eat away because the potassium is so potent. So now we're going to go to hyperkalemia. So hyperkalemia is any level of potassium above 5. The causes of hyperkalemia could be kidneys are not perfusing well, having the patient on a diuretic such as spironolactone because you're retaining potassium. Also, intestinal obstruction if a patient has cell damage, acidosis, Addison's disease, excessive use of potassium-based salt substitutes. So those are a couple of things that can cause hyperkalemia. So the signs and symptoms of kalemia can start off with a muscle twitch, then it can become muscle weakness, and then that patient can have flaccid paralysis, but you also want to be aware of the life-threatening arrhythmias. So treatment for hyperkalemia, the patient may have to go to dialysis because the kidneys aren't working well. Also, the patient may need to get calcium gluconate because it decreases the arrhythmias. And if potassium is being administered to the patient and they are hyperkalemic, you want to immediately stop the IV infusion. And you're going to withhold any type of oral potassiums as well. You want to initiate a potassium restricted diet. You may have to administer sodium polynitrate sulfonate. So escalaxate is the trade name, which is given as an enema because it decreases the serum potassium, and it does this by exchanging sodium for potassium in the GI tract. They may receive IV calcium if it's severe. And then, of course, they may get insulin because it carries glucose and potassium into the cells to remove the excess potassium. All right, guys, so I thought that this video wasn't going to be as long, but because there's so many labs, fluids, and electrolytes, I am going to cut this video short. But before I do, I'm going to read a couple of questions out of this Saunders and NCLEX prep book that I used with you guys the last time. So, question number 1. The nurse who is caring for a client with kidney failure notes that the client is dyspneic and crackles are heard when listening to breath sounds in the lungs. Which additional sign symptom should the nurse expect to note in the client? So we are looking for a patient who has lung crackles in the lungs. So we do know that the patient is in a fluid volume excess. So here are the choices: rapid weight loss, flat hand and neck veins, a weak and thready pulse, and increase in blood pressure. So the question was, which additional sign or symptom should the nurse expect to note in this client? So here we go through the list. Rapid weight loss. That would be fluid volume deficit. Flat hand and neck veins, that would also be fluid volume deficit because it's portraying dehydration. A weak and thready pulse also would be fluid volume deficit. So that brings us to the answer choice, an increase in blood pressure. So along the lines with the patient having wet crackles and lung sound and having dyspnea, they have an increase in blood pressure when they're fluid volume excess because more volume, more pressure. That's the key words. Anytime the patient has more volume, they have more pressure. So that is fluid volume excess. So the answer is an increase in blood pressure. Question number 2. The nurse is reviewing the health records of assigned clients. The nurse should plan care knowing that which client is at a risk for potassium deficit. The choices are the client with Addison's disease, the client with metabolic acidosis, the client with intestinal obstruction, the client with receiving nasogastric suction. So we need to know which patient is in potassium deficit, so hypokalemia, and we know based on the signs and symptoms of hypokalemia, the causes what can cause that is the nasogastric suction. So the answer is nasogastric suction. But if that wasn't an answer choice, if they had vomiting or diarrhea, those also would have been of choice for the potassium deficit, because potassium is excreted by the kidneys and potassium is found heavily in the intestines. Question number 3. The nurse reviews a client's electrolytes results and notes a potassium level of 5.5. The nurse understands that a potassium value at this level would be noted with which condition? I'm going to read the question again. The nurse reviews a client's electrolyte results and notes a potassium level of 5.5. So that tells us the client is hyperkalemic. The nurse understands that a potassium value at this level would be noted with which condition? So, if you have too much potassium, then what symptom would it be? Diarrhea, traumatic burn, Cushing syndrome, overuse of laxatives. So we can use process of elimination right here, because diarrhea and the overuse of laxatives are common and alike, because, if you're using laxatives too much, you are going to have diarrhea. So you could eliminate that because you're losing a lot of potassium. Your potassium isn't going up. You're excreting too much potassium. Cushing syndrome, you are losing too much potassium as well. So the correct answer is traumatic burn due to the hyperkalemia. And I'm going to read this so you guys can understand. So the passage states, recalling that cell destruction occurring with traumatic burns causes potassium shifts. This will direct you to the correct answer. Clients who experience the cellular shifting of potassium as in early stages of massive cell destruction with trauma, burn, sepsis, or metabolic or respiratory acidosis are at risk for hypokalemia. The client with Cushing syndrome or diarrhea and the client who has been overusing laxatives are at risk for hyperkalemia. Okay, you guys, and I'm going to do one last question. The nurse is reading the primary healthcare provider's progress notes in the client's record and sees that the PHCP has documented insensible fluid loss of approximately 800 mL daily. Which client is at the risk for this loss? So the key word to this question is insensible fluid loss. So we know insensible fluid loss we cannot measure, correct? And sensible fluid loss are things that we can measure, such as urinary output. So sensible fluid losses are urinary output, wound drainage, and gastric secretions. So our answer choices are, which client at the risk for this loss? Choice number 1, the client with a draining wound. 2, the client with a urinary catheter. 3, the client with a fast respiratory rate. And 4, a client with a nasogastric tube to low suctioning. So we know that a draining wound, you can measure the output if the patient has a wound vac, so that wouldn't be the answer. A client with a urinary catheter, you're actually able to measure urinary output, so that isn't the correct answer either. A client with a nasogastric tube to low suction, that suctioning goes into a certain container, so you're actually able to measure that as well. So that is an answer. So that brings us to the answer, the client with a fast respiratory rate, because you cannot document a patient that is losing fluids that is experiencing a fast respiratory rate, or if they're sweating and what have you. Okay, guys, I hope this review helped you guys. I definitely will be doing another video or two on the labs because I need to go over calcium, magnesium, as well as phosphorus. So I hope this video did help you guys. I'm going to do more questions on the next video as well. I just kind of wanted to get you guys updated and let you guys know what's been going on, and I just really wanted to kind of get to know you guys as well. And y'all definitely will pass this NCLEX. Stay positive. Use your resources that you can, such as Sounders, Hearst, UWorld, ATI, Mark Clemic. It would definitely help you guys. All right, see y'all later.